Think forward. Think Research Channel.
There's a structural problem with genocide, which is that it tends to happen in places that are off the beaten path.
So now, in order to promote nonviolence and reduce violence, ultimately we have to address the motivation.
Society needs to acknowledge that learning is a lifelong challenge.
The sit-ins challenge cherished beliefs most whites held dearly.
At the DNA level, we're all 99.9% the same. All of us.
So individuals do matter. And I think the quality of our individual leadership matters.
Who is speaking for poor people? 40 million Americans make $6 an hour. Who is speaking for them?
The only thing that one has after throwing everything overboard is the love that one can give.
To nobody's surprise, estimates of the number of homeless people in the U.S. have varied hugely, from fewer than 500,000 to over 2 million a year. Some are based on sophisticated sampling techniques, others on educated guesses, and in the company that I tend to hang out with, on rants and anger and whatever we can get that day. Variation, however, in the numbers is more than a case of rigor, missing or not. It's fundamentally an issue of who should count as homeless, not simply because in my anthropological world we like to classify people by status or some other measure of where they fit in a larger social configuration, but because to be classified as homeless is to, or have conferred, an implicit claim for assistance. It's an embodied statement of an unmet need. And that embodied statement implies a reciprocal obligation somewhere that that need ought to be met. We can talk about how, but that it ought to be met somewhere. So a lot of the disputes over how many are really disputes over who should count rather than how best to do the enumeration. Nonetheless, the data we have at hand, for all their imperfections, suggests that the magnitude of this need, for health purposes we might call it a variable exposure, is considerable. Look for a second at the shelter turnover rates in 2 cities whose records make this kind of analysis unusually possible. That lower line, the lowest line in this figure in particular, I want to draw your attention to. A young African-American child in New York City today has a 1 in 6 chance each year of spending time in the public shelter system. If we assume that rate is, or that risk is constant over his or her childhood, homelessness of some varying duration becomes almost a rite of passage. The numbers are no more reassuring on the national scale. Again, this is the best evidence, I think, that's out there. Some 350,000 people homeless in any given week in the late 80s. That figure is now some 800,000 any given day, and from 5 to 10% of poor people. Now, the point all these large numbers are driving at is that it's a much more commonplace phenomenon, transient, episodic, or enduring as the case may be, but a much more common phenomenon in the lives of ordinary people than we typically think of it as being. And the most important determinant of that remarkable step change in the career of this social problem has to do with the lack of affordable housing, the remarkable disappearance of affordable housing in the last roughly 25 years. So this is the basic mechanism, I think. If we were modeling homeless risk for epidemiological purposes, we'll have a lot to say about personal vulnerability factors in a minute, but the context in which those vulnerability factors or those risk factors play out is the following. When you have too many people chasing too few units, somebody gets left out. It's not quite an arithmetic zero-sum game, because obviously a lot of doubling up goes on. Who gets left out of that game, in turn, has a lot to do with personal characteristics, but the underlying constant in the equation is that there aren't enough places to begin with. Now, the public health response to this was early and uncharacteristically fierce. Housing, as many of you know, has a long-standing, honorable position in the charter of public health, beginning with sanitary reform in the mid-19th century. In our own decades, recent decades, the American Psychiatric Association was the first to weigh in the early 80s, reviewing the basic epidemiology, doing what they could to produce a clinical profile of homeless men and women, identifying some early, even then, promising approaches, and making an extremely well-hedged acknowledgement that basic needs were at issue. Their phrasing, artful, even to this day, is that the homeless have a right equal to that of others to have their basic needs met, without, of course, ever asking, where exactly is that right lodged for all those others, and under what auspices? 4 years later, an even more remarkable document, the Institute of Medicine, which was an unusually contentious document, weighed in with a sort of three-part model for how public health and homelessness relate to one another. Health disorders can cause homelessness. The reverse is also true. And in any event, homelessness radically complicates and compromises any effort to deal with existing health problems. That document was remarkable not for its science, which was sober, very careful, peer-reviewed, but for the unwillingness of 10 of its 13 members to sit still with the science. What kind of problems are we talking about? Most of these, I have to say, were identified in the early 80s, and if anything, it's simply the configuration or the rates that have changed and not the substance of the picture. By and large, you can see this as an argument for what in other contexts has been referred to as the weathering effect of poverty. One could simply observe that that's unusually intensified when one is spending time in shelters or on the streets. But it crosses the gamut of health disorders, from infectious disorders, and in particular TB and HIV, the hepatitis B and C, chronic health conditions, mental health and substance use, which have, of course, a much larger share of the public's impression of homelessness, as well as unusual injuries suffered by kids who spend a lot of time in shelters and out of school and in no stable housing circumstance. There's one somewhat peculiar and macabre point of intersection when social worth and functional status are essentially equated by a quirk of fate. And homeless people wind up being picked up and discarded along with the rest of the trash. Now, this is not a distinctively or unusually American phenomenon. Again, this is a fairly unsystematic and simple-minded survey. But if you look at street deaths alone, it's remarkable how the public health profession has begun to pay more attention with, again, its sort of obsessive-compulsive concern with calculations and precision, and can give us things like standardized mortality ratios for the street deaths of men and women in Toronto, street dwellers in Osaka, Copenhagen, Moscow, Istanbul, Toronto, and Sao Paulo in Portugal. This is still a contested endeavor, however, despite the sort of best efforts of public health authorities out there. In my own city, in New York, the medical examiner's office, to this day, has stonewalled the city council in calculating and posting the number of homeless street deaths per year. They make a variety of arguments. The oddest of all is that this would somehow violate the confidentiality of the dead person, even if misnamed, merely describing them could enable somebody to identify who it might have been. It's not been very persuasive to the City Council. It has, however, held up the possibilities. I should also mention one really unusual attempt to take the measure of the public health consequences of homelessness. Margaret Morton, an unusual and intrepid photojournalist, worked her way into a squatter settlement on the Lower East Side in New York some 15 years ago and began to do a photo documentary account of the lives of the 24 or so people living there. These are bona fide squatter surrounds. They would get their water from fire hydrants. They would purloin the electricity from lamp posts and do what they could to provide heat and security. That community was evicted under the pretext of a fire in the early 90s and dispersed to the four winds. And Margaret was left with this trove of extraordinary photographs and tape recordings of interviews she had done with the residents, and stuck. She had no consents to publish any of this. 10 years later, one of the original group got in touch with her, put her in touch with the remaining living members of that original collective, and they together signed off on the book that has come out last year as Glass House. For my purposes, the interesting relevant feature is that of those 24 people, 4 have died in that 10-year period. 2 from chronic disorders, heart and liver respectively, 1 from a drug overdose, and 1 from a motorcycle accident. Regardless of how you do the calculations, that's a fairly elevated mortality rate. All of them were younger than 42. But here's the problem. Is healthcare the real problem here? I mentioned the Institute of Medicine report earlier, and I want to return to that now. The report was never covered in the popular press. The 3-page supplemental statement signed by 10 of the renegade scientists was, as front-page news. What was the news? Not that they could document the health consequences of homelessness, but that wasn't enough. That they had to step outside of their scientific role and express what they described as the simple human cry of protest, that we allow this to persist in a nation that could easily afford otherwise. These were not radicals. These were not the sort of socialist medical scientists sort of secretly imported into the halls of the National Academy of Sciences. These were your standard, decent, hardworking, grind academic physicians and public health workers. And this was the protest they lodged. But here's what the chair of this report said several years later. Even then, he said, we were uncomfortable in talking about health care, but that's what we did because that's where our expertise lay. We talked about the health problems of homeless people because that's what we treat. That's not what the fundamental problem is, Vladeck went on to say. And unless we address those more basic structural sources of homelessness, we can expect to make, at best, a marginal difference in dealing with the disorders themselves. That turns out to be not such a new lesson. Writing about the Victorian observers of the mid-19th century, the sort of renowned public health historian George Rosen noticed that even then it was clear that for all we knew about the individual failings, deficiencies, the bad habits, and otherwise moral failings of these individuals, what was fundamentally wrong with these folks was their poverty. Given that, and given the depth with which that observation and the history behind that observation, does applying a public health framework to this problem help? What value does it bring to the discussion? Well, we have 2 versions of that. One is what in anthropology we call the argument for ethnography. That's essentially this. You write 500 pages of unbelievably detailed information about everyday life in order to say 5 pages about something general that can be applied elsewhere. What you've done in the 500 pages is to earn the authority to make the larger observations. Well, the public health version of that is William Breakey, also a renegade member of that original IOM cadre, writing 10 years later, saying essentially the same thing they had said 10 years before, is that from a public health standpoint, as clinicians, it makes no sense for us to do what we do and simply throw people back into the same fast-running stream. Unless we can figure out who's pushing them in upstream, it's ludicrous and self-defeating to simply pull them out, refurbish them, patch them up as best we can, and then set them on their way. A slightly more abstract version of that problem, Schwartz and Meyer worried very much about applying the tools of public health to what public health studies best, individual-based risk factors, as a possible distraction from what it doesn't do so well but ought to be recognizing all along, that those risk factors only convert to homelessness under certain structural conditions. It turns out that public health is a lot less adept at identifying those structural conditions, where they come from and how they might be changed, than we are in cataloging the individual deficiencies that put people at increased risk of homelessness under those conditions. So, what do you do? Well, it seems to me there's at least two things that first need to be said. One is that the expertise needed to treat people under conditions of homelessness may not be the same expertise needed to forge preventive solutions to homelessness. I know a lot about surviving on the streets. I don't know very much about financing large-scale public housing at all. But I think the second competency is what's needed to fundamentally address this problem in any kind of long-term or lasting fashion. And Martha Burt, capping 2 decades of work on her own, essentially says it straightforwardly enough. Unless you can provide people with housing, all the health care in the world isn't going to do much except get them through the night. And this, in turn, I think, has lessons for the prevention as well as the sort of lasting treatment of homelessness, if that's the right verb. So what do you do for research as well as practice? Well, I think the first thing you do is stop studying homelessness as though it were some exotic locale or niche or virtual community in its own right. And you'll find out there articles and books about the culture of homelessness, as though it, in fact, were some kind of functional equivalent of a native space, happily and conveniently enough located in our inner cities. But to break out of that sort of misplaced ethnographic assumption and make the larger connections, not to street, but to the ordinary struggles and makeshift economies of the working poor. You see that in work that Barbara Ehrenreich has done, that David Shipler has done, that Eden and Lyon have done with welfare families, and that Sharon Hayes here in the Department of Sociology has done with women after welfare reform. The second thing I think we can do is to look at what moves large numbers of people from one institutional setting to another. People arrive in shelters from jails not because they have a peculiar internal compass that leads them there when they get out of jails, or from psychiatric facilities. They go there because that's the only option they have, and that those institutions no longer do what used to be called discharge planning. As far as they're concerned, the shelter is there to do that for them. And this is the kind of supply-side push or attraction that guarantees that certain people will be concentrated there if they no longer have a warrant to live someplace else. And then last, I think we do need to, as researchers, attend to this notion that housing makes a difference, say how it makes a difference, and show how much in the final analysis is actually saved by making a difference. But the fundamental lesson is a really old one. Some of you may remember James Agee and Walker Evans' account of tenant farmers in Alabama that appeared in the middle of the Depression, actually was commissioned by Fortune magazine, which then refused to publish it. And among everything else that was put into that encyclopedia of sort of documentary detail on the lives of tenant farmers, this note somehow got dropped. and the historian William Stott found it. And it strikes me as a really good way of summing up the mistake we make with homelessness all too often. That it's not that we need to understand it better on its own terms, but to refit it, reconfigure it as part of much larger patterns of survival and makeshift and striving and just getting by and then not getting by in the larger society. And that seems to me is where we ought to be focusing both our interventions and our research. Thanks very much.
You really covered some of the things, Kim, that I wanted to say. Like I wanted to start by saying that, you know, we don't want to just think of homelessness as this peculiar, exotic condition that some people have, but really think of it as a condition that menaces an awful lot of people in this country. Minimally about 25%, because that's the number, the percentage of the population that turns out to be poor if you base your calculations of poverty not on the obsolete, you know, food-based system the federal government uses, but on a more realistic one that takes into account things like rent and health care. And I want to also add to that, and what I have to say, is that not only is health care maybe not the central issue in trying to solve homelessness or poverty, but that the costs of health care may be becoming a contributing factor for many people's poverty and near homeless status. Let me just start by saying a little bit about my experiences when I worked on the book Nickel and Dimed, and I entered the low-wage world, attempting to support myself as a waitress, a maid with a house cleaning service, a hotel housekeeper, a nursing home aide, and a Walmart associate. There are no employees anymore in the world. They're just team workers and associates. Anyway, I averaged $7 an hour in these different jobs. And the big problem was rent, not health care. Well, you know, obviously, in the short times that I was working in these jobs and everything, I wasn't going to be utilizing a lot of health care anyway. But rent was the overwhelming issue. Just a couple of examples. In Key West, Florida, where I started out and worked in the hotel and restaurants there, I got into the trailer park in a nearby key, and I thought, you think trailer parks, right? That's really going to be cheap. That's how low can you get? Well, it was $625 a month then for a half-size trailer, not counting utilities. And you've got to have air conditioning. This was June in Key West, especially if you live in a tin can, which is essentially what I had. So think about that, $7 an hour. That gets you about $1,200 a month. If you have, say, $700 of that going to rent and utilities, you're left with $500. If you were to have child care expenses, that would be, say, $500 right there, and you're already in negative numbers. I didn't. I couldn't get my kids to come with me. One of them, in fact, is teaching at the law school here and didn't want to go live with mom in a trailer park for a while. But if you don't have a child, still, if you have some transportation costs, you are very close to the margin. And, of course, taxes for an individual, you're down to $1,000 a month to play around with. Minneapolis, in the Twin Cities area, I could find nothing for under $800 a month. And all I wanted was one room with, like a microwave and a fridge in it. Nothing. No trailer parks. I ended up in doing what a lot of the working poor do, which is you go into a motel, a residential motel, which it's expensive, although these are usually the shabbier, grubbier motels, but you don't have to put down a first month's rent and security deposit. You can walk right in, have a roof over your head, and this was in remarkably creepy circumstances. I hated this place. It was dirty. It was not safe. I had no fridge or microwave, so all of my food had to come from a convenience store. I couldn't even, keep anything overnight, or fast food, and that's expensive. That's a lot more expensive than being able to stop in a grocery store, So you see your cost mounting right there. By the way, I felt really sorry for myself in this dump until I began to, look around and get to, see the people coming and going. They were all long-term residents like me. And I realized then I lived in relative luxury because the other rooms in the motel were occupied by whole families, meaning that queen-size bed you get was the desk and the dining room table and everything for them. Now, the rent in this place was $250 a week, which was more than I was making at Walmart. For many people, the residential motel is the last stop before homelessness. You get sucked in. I've met families who did it because they wanted to keep their kids in the same school when they were evicted from their last place, so they went into a residential motel to preserve some stability for their kids. And then, of course, you're quickly out of money, and the next step would be the streets. Now, people, of course, a lot of people do get by, and Kim mentioned some of the ways that you do that. One is that you live with a lot of other people who are contributing their relatively low individual wages. And that could be a spouse, or it could be grown children. But I was also struck by the number of people I met who were in fairly ad hoc arrangements, living with somebody they had just met fairly recently. And those are bound to be unstable arrangements. It's particularly hard on single mothers. It's hard enough to match yourself up with somebody who you're going to get along with and who isn't going to hit on you, or whatever the problems might arise, but to also get somebody who you feel good with having your kids around can make it a lot harder, or who wants to be with kids. So those are shaky. You can also, of course, work more than one job, which is what is the most common solution. I also met a lot of people, though, who just weren't making ends meet, weren't putting, managing no matter how hard. I did work with women who turned out to be homeless. These are full-time working women, homeless. I had to confront my own stereotypes then, because I think I had my stereotypes, pushing a shopping cart kind of thing. These women, they looked fine. They were well-groomed. They were clean-looking when they came to work. And that's just a testimony to the remarkable ingenuity it takes to pull off homelessness and a job. Finding the place where you can get a free shower. Using the electrical outlet somewhere in your place of work to blow dry or do the curling iron or whatever you're going to do. Using consignment stores, etc. So my challenge to you, and I'm echoing Kim here, is if you take the service ethic of your professions seriously, and I think most people here are health professionals or in training to be, then you have to extend your concern beyond the immediate medical issues to other factors in people's lives that are producing poverty and all the problems that go with it.